good afternoon. I am so excited to talk to you about something I'm very passionate about, and maybe I'll connect with everyone in this room and you'll leave being passionate about it as well. Teams in healthcare. It's a topic I think about on a daily basis. And I first want to start because I think I have an assumption about all of you in this room. I think you've all been in your lifetime on a winning team and on a losing team. And you can probably think about what that feels like. I have 2 small children, and already they're on many informal and formal winning teams and losing teams. And it's an interesting concept. We're sitting in a basketball stadium here, and that's okay when you think about adults on maybe professional teams. But when you walk into a hospital or you walk in to go see your primary care physician, you probably don't think, does my nurse feel like she's on a winning team? Does my surgeon feel like they're on a losing team? Do I feel like I'm on a winning team or a losing team? But really, when you start thinking about the basic unit of teamwork in a healthcare setting, it's a really important foundational component that we need to train our future providers to be a part of and to contribute to. I started thinking about teams early in my career. I started at the University of Southern California. My dissertation work in educational psychology was on expertise. Now, I like smart people, and I picked surgeons. They're very smart people, they're task-oriented, and they definitely develop a real expertise in their field. And when you start to think about how can you bridge the gap from a novice trainee to an expert surgeon, you have to deconstruct that expertise. And I used to think it was the psychomotor skills, how they throw a stitch, how they tie a knot. But really, it was when they zig and zag and how they make the decisions they do that we needed to deconstruct. And in fact, when you put an expert surgeon with a novice surgeon, they have a hard time articulating why they did it because it's become automated for them. They've chunked those steps together. So how could we break this down as an educator was something I spent a lot of time in my early career doing in the simulation center. We would have task trainers and procedural trainers, and we would try to bridge that gap. Now, surgeons can't spend all their time in a sim lab. They have to be in the OR. This is something that they like to be in. So we shared our sim lab with some other people. And one of the educational groups, was the U.S. Navy. Now, the U.S. Navy picked the Los Angeles County USC Public Health System as their trauma team training center. And they would bring their Navy healthcare teams to do intensive 30-day training before they were deployed to Afghanistan or Iraq. And they would use our sim center. And on the Navy days, they would come in and they had stuff and they had people and they were efficient and they knew exactly what they were doing and the tone of their discourse was flat. They would do their scenarios and they'd debrief and they knew exactly what they did right and exactly what they did wrong. I was like, wow, this is kind of impressive. It kind of scared me a little bit. I was like, imagine if we did that with our surgeons. I wonder how they would interplay with that. And it really became a need that I started to identify that I don't think we do in maybe our civilian training. What does this mechanical teamwork component look like? And it was absent from our education of our trainees at that time. Then I was fortunate enough, and my career took me to be on faculty at Harvard Medical School at Brigham and Women's Hospital, and I arrived to Boston a little nervous and excited, and they were doing team training. But their team training was around patient safety and error detection. It was about looking at the bottom and bringing it up. We're going to create these efficient teams and these effective teams to prevent error and safety. I was like, okay, I get that. And I had the chance to work with someone who I really like to read, and I recommend to everyone Atul Gawande, who's a surgeon writer, who's written in the New Yorker, and has written some wonderful books. And he talked about the old training model was we created cowboys. They were on their horse in the Wild West, and these physicians were going to go save the Wild West. But what we needed to do was train pit crews. Patient comes in, we swarm the patient goes out. Next patient comes in, we swarm the patient goes out. We have a tire specialist, we have a gas specialist, we have a window specialist. I was like, okay, well, that's kind of interesting. That's the nurse and the anesthesiologist and the surgeon. And that was a different framework. So I thought that was interesting. And I had a chance to receive a grant to do some OR team training. We were going to take attending level surgeons, anesthesiologists, and nurses and have them come and do some OR team training to improve team safety. And this grant said they wanted us to teach 3 objectives. Now, as an educator, I'm all about my objectives. And these objectives were closed-loop communication, assertiveness, and using a chase safety checklist. Dream job, right? I get to work with fancy pants, Harvard, surgeons, anesthesiologists. I only have to teach these things. Three things. We're getting paid for it. This is great. So we had fun. We created scenarios, and we had a whole training program. They were going to come for 6 months. And when you do simulation training, you want to make sure your fidelity's right, that you give them enough tools that are like what they use in their real environment to be successful. And you want to give them a clinically challenging case, but you also want to make some twists and turns because it creates conflict or a need to discuss things. So our first scenario is we want to take these OR teams and attending. They're done with their training, they're getting paid, and they're on staff at the Brigham. We wanted to take them out of the OR, and our first scenario was in the recovery room. Because we know when we take teams out of their microsystem, they struggle a little bit and see how they can handle it. So the first case, we'll call him Mr. Monson. And the team walks in, and he is in the recovery room, which is the room right after surgery, and it's a simulated patient, a mannequin. And the team acts pretty much how we think. The surgeons go in, and where's the chart? I need the chart, and we're going to solve the problem. They had the cognition. They're going to solve this puzzle piece. The nurses go into the room, and if any of you are healthcare providers, you know a nurse is not a nurse is not a nurse, that they fine-tune and hone their skills in the different environments. So when you take OR nurses and you put them in the recovery room, there's different equipment, there's different drugs they would push, there's different everything. So it gets them a little unsettled. They're in there, they're looking at the inventory and the equipment, the feeds of information they have. And then we had the anesthesiologists who we thought would be the leaders in the room. And there were two anesthesiologists. One was senior, 20 years of experience, and one was 3 years out of training, had completed all their training, had been working for 3 years. And they walk into the room, and the senior anesthesiologist goes into the code card. And she's looking for stuff, and the patient's back here. She has her back to the patient. She's looking. We're like, this is interesting. The person we thought was going to be the leader didn't do it initially. The junior anesthesia attending goes to the head of the bed and starts bagging the patient and looking around and taking it all in. Now, they struggle. They're having parallel conversations amongst the dyads for a while. For 90 seconds, maybe 2 minutes, and in the sim world, we're like, oh, this isn't good, this isn't good. When are they going to engage? They got to come together. And the junior anesthesiologist says, I'm worried about a PE because the whole room turned, focused, was facing the patient, and information started to flow. They had their framework. They knew what they were going to do. But that junior anesthesiologist remained the leader of the team and continued to give orders and process and give direction and became a team member. Success. We walk down the hall, and we're going to go debrief this simulation because we think that's where the real learning is. Let's reflect on our shared experience and talk about it. And whenever you work with smart, accomplished people and you put them in a room after they've done a performance-based assessment, they sit around the table and you say, how'd that go? How'd that feel? And they go, oh, horrible. That was horrible. You know, we'd never have that equipment. Things would be different, and it's never like that, and I always do it perfect when I'm in the environment. Well, that's good. They're getting off their emotion. And then they circle around and they start saying, yeah, but, you know, we figured it out, and we solved the problem. We stabilized the patient, and that was very complicated, and it was good. So they're coming together as a group. They're coming together as a team. They're starting to develop an identity. Then I said, can I ask, was there a leader to the team? And they said, one of the surgeons sits back and goes, that's an interesting word, leader. I mean, aren't we all leaders? Aren't we all leaders here at Harvard? I mean, I'm never not a leader. What do you mean, not a leader? When would I be a leader? What do you mean by that question? Well, I'll reflect it back to the group. Was there a leader in the group and do this? And some people were kind of quiet and didn't say anything. And I turned to the junior anesthesiologist and I said, well, what I observed was that you were the leader. And you were the leader because you gave the framework for the team to come together and move forward. And she goes, oh, no. My colleague has the expertise in the room, and it was really a group effort. And that's when I knew this is more than a pit crew. There are powers in play in healthcare teams. They're about hierarchy and culture and power. It's three-dimensional. It's not just training people how to take the wheels off a car and do it efficiently and effectively over time. There's another element to this in our complex system. And then I swear to goodness, I came to Rochester and it all came together for me. I met a wonderful woman named Maddie Schmidt. Maddie Schmidt is an internationally renowned theorist and writer about interprofessional education. She comes from the nursing world, and she gave us, and 2 years ago, she was the lead author on a very important document that was endorsed by the top organizations in medicine, nursing, pharmacy, dentistry, and social work. And she defined the core competencies for interprofessional education. She says, we need to learn with, from, and about each other so that we can provide our great care. That it's not enough that in our different disciplines we know how to treat and manage and diagnose from our specialty, but we also need to be experts in how to communicate, collaborate, and coordinate. And we have to deliberately teach it. We can't just think people come to us with this innate knowledge of how to do those things, and our curriculum needs to encompass that. My future vision of Dream Teams is just that. It's a round table of specialists and providers who come together and share their expertise, but their expertise is not just in how they practice medicine, but it's in how they communicate, coordinate, and collaborate with each other. And a big component of that is you, the patient. The patient and your families are not the subject of our teams, but you're on the team. You get a jersey. You're on that, and we need to train providers who can help you have a voice and feel empowered and integrated and can help direct the team. Those are the things we're thinking about, and I really appreciate the opportunity to come share that with you.